Welcome to Mayo Clinic's ECG segment, Making Waves, continuing medical education podcast. Join us for a lively discussion on the latest and greatest in the field of electrocardiography. We'll discuss some of the exciting and innovative work happening at Mayo Clinic and beyond with the most brilliant minds in the space and provide valuable insights that can be directly applied to your practice. Welcome to Mayo Clinic's ECG segment, Making Waves. In this episode, we explore one of the most significant advances in catheter ablation in recent years, pulse field ablation, or PFA. As this technology has rapidly gained adoption across the United States, many clinicians and patients alike are asking some of the same questions. What makes it different? Is it safer? Is it better? And what should we expect moving forward? Joining us today is Dr. Christopher DeSimone, a cardiac electrophysiologist at Mayo Clinic. Dr. DeSimone is an associate professor of medicine in the Division of Heart Rhythm Services at Mayo Clinic in Rochester, Minnesota. He specializes in complex invasive electrophysiology ablation procedures and has authored well over 400 publications, including more than 250 peer-reviewed manuscripts. He is named co-inventor on over 50 patent applications, several of which have been licensed. He lectures nationally and internationally on cardiac electrophysiology, even here on our campus that many of us benefit from. And his research has focused on translational innovation in ventricular fibrillation. He currently serves as the director of the Heart Rhythm Services Research and director of marketing for the Mayo Clinic Cardiovascular Enterprise. Dr. DeSimone, thank you again for joining us.
Thank you, Anthony, so much. Thank you for doing these. I'm excited today to talk about atrial fibrillation and this pulse field technology and whatever I can to help patients better understand what they may choose to go through to help them in their journey with atrial fibrillation.
So we've seen so much of this changing the field, especially with how our patients and how our, colleagues are asking us about this. But maybe you could kind of help us understand what is this pulse field ablation or PFA, that we're commonly using today in our practice here at Mayo. How does it differ from the traditional approaches? And have you seen any differences even in the risks of the procedure itself?
It's a great question. So this is one we always discuss with the patients, and always a lot of patients have questions about. So I'd say the goal for catheter ablation when we're doing atrial fibrillation procedures is to isolate the muscle tissue in the pulmonary veins. And that's kind of the area that's bringing oxygenated blood from the lungs into the top parts of the heart, and we pump it out to the rest of the body. We think these muscle tissues are the most responsible areas that harbor the triggers that can initiate atrial fibrillation. So we bring a patient into the electrophysiology lab. We get access into the blood vessels in their legs and groins and maneuver these catheters up into the heart very carefully. We go over to the left chamber of the heart called the left atrium. It's on top, and that's where the pulmonary vein muscle tissue connects to the left atrium. And what we try to do is kill that tissue on the outside of that muscle sleeve so that we short circuit the electricity from getting into the atrium and thereby trying to prevent atrial fibrillation from starting or initiating. Traditionally, we've been using, I would say, the last 20 years or so, thermal approaches. So we'd use heat with radiofrequency ablation, which would generate resistive heating, or we'd use a cryoballoon to try to freeze the tissue to kill it. I'd say the last few years, we've really taken off and pivoted as a field to where the default or very commonly used approach is pulse field ablation. And what we do with these catheters are deliver high voltages over very short periods of time to almost electrocute the cell tissues, if you will. And that causes the cells to burst open and die off. It's a less thermal approach. And given some of the safety benefits from the pulse field, we're able to ablate that muscle sleeve tissue directly rather than simply isolate it. Now, some things we make clear to our patients. This is not a magic wand. It's a newer technology. There's still things we're learning, but it's really taken off in this field. I'd say this is overwhelmingly the predominant means we all go about if we have the technology at our center. Now, it's early, but I think more and more people will take this on and more centers will. Early on in these stages, there's so many different catheters and things to choose from. Everybody's still trying to find which is the most comfortable one to use or which is the best one to use. But again, that's all good for our patients because the technology refines itself. Now, the reason it's taken off not only because it's more efficient procedure, meaning we're under general anesthesia for a less period of time, but using that less non-thermal approach, it's far safer in terms of procedural complications we were concerned about with thermal ablation. And these would be the atrioesophageal fistula, where there could be a connection of the heart to a hole in the esophagus, phrenic nerve damage, which is the nerve that stimulates your diaphragm so that you breathe up and down, as well as narrowing of the pulmonary veins themselves called pulmonary vein stenosis. Those are exquisitely rare with thermal ablation, but even less so with pulse field ablation. So much safer in that regards, which is an excellent thing for patients, an excellent thing for proceduralists like myself. That said, there's still some associated risks with the procedure that we're still learning and still happens very infrequently, but we're not able to understand it completely. And requires still ongoing study. In this regards, microbubbles that are generated with the pulsed electric field procedure, vasospasm or tightening of the coronary blood vessels that feed the heart, as well as popping open these cells. This could lead to clogging up of the kidney at times in certain individuals. We're trying to figure out what this means and how to minimize those as best as possible for patients. But I think given the differences in the catheters now, in the delivery procedure, it's much more efficient. You're under general anesthesia much less time, and this has a lot of benefits overall for our patients.
So we've learned, so much of how this is improving the speed, but there's also risks to, starting more circuits, even causing too much scar in the heart that it can have its effect. Let's say I'm a patient with atrial fibrillation. I think the common thing that someone in my position, if this is still brand new, and maybe if this is new diagnosis or this procedure's come up, can you kind of walk me through what your approach is to someone, on the day of, or what to expect going into a procedure like this?
Absolutely. So one thing I could say about the electrophysiology lab, we're putting catheters up in the patient's hearts. We don't have them on bypass. We don't have anything to stop the heart. It's moving. And we're doing this by X-ray. We're doing this by signals we see from the catheters we put in the heart. We're using intracardiac ultrasound. The last thing you want to do is be very fast or race during an ablation procedure. You want to be very careful and meticulous what we do. Now, being under anesthesia a shorter period of time definitely has its advantages, but the things that we're doing are very invasive inside the heart. So we want to be very careful. So I would say the efficiency of the procedure is within the ablation catheter itself. And we need to be cognizant that just because we could deliver energy more efficiently, it's not a license that we should ablate more just because we can. There's still no data to support that doing anything outside of durable pulmonary vein isolation, those trigger areas, is better for our atrial fibrillation patients. And in some cases, more can certainly be worse. Think about it. We're killing this tissue off. Now, it's a small amount of tissue, but we're killing this tissue off, and we want your body to form scar in these areas over the next few weeks post the ablation procedure. And that could be with its own set of problems. For example, you could create new tissue circuits that not cause atrial fibrillation, but could cause a cousin or a relative called atrial flutter. And that could give patients the same or similar symptoms to when they're in atrial fibrillation. In essence, you're trading one problem for the next. Also, if you do an aggressive amount of ablation, you can make the heart more stiff because it's been scar. It's not live tissue anymore. And that tissue not being alive anymore doesn't relax. And without relaxing, that area is connected to your lung pressures. And if the pressure is high in the top part of the heart, which we see commonly in patients who develop AFib or who've had too many ablations for atrial fibrillation, that can make patients short of breath regardless of if they're in atrial fibrillation or not. So I would say just because we can do more, because we're able to do the procedure more expeditiously, doesn't mean we should. So my approach remains the same. Make sure the pulmonary veins are isolated, and then look for lower hanging fruit or other triggers or events that I know or I think in that certain patient will benefit them. I think the other
Now,
thing we need to be cognizant of is every patient's different. They'll have their own set of other diseases. They'll have their own sized atrium, some larger, some smaller. These atrium are all different. They have varying levels of scar. There's different pressures in patients' heart from one person to another. We really need to individualize patients' approach when we do catheter ablation in these patients. It's really part, you would say, of more of the art of catheter ablation for atrial fibrillation. And that shouldn't change just because we've changed catheters or delivery to pulse field ablation.
So we're learning how much the field has really evolved with just this technology of the catheter itself. But that doesn't mean we speed up things or do things any differently. We still want to take our time. And you've talked about the risks of these procedures, despite all the benefits that we have. Now, say I'm a patient, new onset atrial fibrillation, maybe coming in and out of atrial fibrillation. And I've heard about this procedure and this new technology. What is your general approach of someone coming to you, of walking them through the procedure, and what can I expect, the day and thereafter?
This is perfect. The patients will love hearing about this, so I'm glad you asked that. I think it's very important. We have to understand we're all different. We have different sized hearts, different structural variations of our hearts, other diseases. Everyone comes in different shapes and sizes and ages, and that's true with the heart as well. We're not advanced to the point yet where we could cure atrial fibrillation. This is a chronic disease. We're really good at treating atrial fibrillation, especially if the patient has paroxysmal atrial fibrillation. You're coming in and out of it. It's self-limiting. If you have more advanced atrial fibrillation, which unfortunately becomes really common because we're unfortunately getting the patients later, or by the time they get to cardiac electrophysiology, they've had atrial fibrillation for quite some time. When that happens, it's more than just the pulmonary veins. There's other tissues inside the heart, inside the left atrium, aside from the pulmonary veins that could be responsible. And that's why our efficacy, how well the AFib therapy works in these patients, is poor. It's still better than drug therapy. But that said, I tell my patients my approach is look at this as a chronic disease. And we use a combination of therapies in addition to treating your risk factors like hypertension, diabetes, and sleep apnea, that in the procedure that day, it will, quote, work. A lot of patients, especially when I do a lot of patients that have had atrial fibrillations from other centers and they're coming for redo ablations, they tell me, I had an ablation, but it didn't work. The procedure works. We set out to isolate the veins acutely during that procedure. Before you leave the lab, we'll get those isolated. What we don't know is, will those veins reconnect? Will those veins stay isolated? They could reconnect, and then we have triggers for atrial fibrillation all there. We don't know what additional places in the heart are needed to be ablated next. And of course, we don't want to ablate everything that could lead to atrial fibrillation. Otherwise, we're going to create additional problems, as I noted above. And many, many patients require a combination therapy. So some of my patients prefer to be on drugs. Some don't want to be on drugs. They want ablation only. Some of my patients, especially those with more advanced atrial fibrillation, and they've been on several ablation procedure regimen, require ablation plus drug to remain them for normal sinus rhythm. So I'd say it's not an all or none approach. It's not a failure if you need a drug in addition to your ablation to stay in normal rhythm. But that said, overall, I think we've been seeing a lot of great benefits from ablation, and it's part of their therapy for the chronic disease. It's not the whole thing. We don't have data yet to suggest that pulse field's any better than our prior thermal approaches, but I think anecdotally it seems like it's really good at keeping the veins durably isolated. And it'll probably end up, as we study this more, being better than cryoablation at a radio frequency. As far as what to expect on the day of the procedure, for example, I'd bring you in, Anthony, today, and we do testing, and we'd visit with you in clinic and go over what to expect during the procedure, how we're going to do it, any questions you have, and make sure you're teed up for that procedure the next day. The following day you come in, we do procedures throughout the day, so you'd either be coming in the morning or in the afternoon. We do the procedure, which takes a few hours to several hours, all depends. Again, we want to take our time, do the very best job we can for you. 2 hours afterwards, you're laying flat. That's after we pull the sheaths to get access through your groins out. And we want to make sure you don't have any bleeding through your groins. So the worst part of the procedure is usually when you lay flat afterwards for 2 hours. Afterwards, we have you up, ambulating, eating, drinking. And then patients usually that evening go back to their hotel, or they'll have a patient family member drive them home. And I would say a restriction of about 5 to 10 pounds of lifting or straining for about 7 days. And I tell my patients after that week, they could go back to doing whatever it is they enjoy. I don't have any limitations outside of that. I then bring my patients back in about 3 months, reevaluate how they've been doing after the ablation procedure. Sometimes at that time, we'll stop a drug if they're on it. They're outside of that, what we call blanking period, that 1 to 3 months after the ablation, patients are healing. And because the heart's been scarred and it's been inflamed, it's healing. And that healing process can cause atrial fibrillation that we don't really know what that means. So we kind of say, let's blank our eyes if that happens and start the clock from time 0, 3 months afterwards and forwards. And then every patient's different. And you come up with an individualized plan with the patient on basically what they have in terms of atrial fibrillation substrate, what we've done during the procedure, and how we move forward is basically always what we learn from the procedure that day. How big their left atrium is, do they have any valvular disease, what the chronicity of their atrial fibrillation is like. And I think this is great progress for the field and a great recipe for patients. And as we continue to learn more and newer generation devices are coming out, I think it's going to further refine the procedure. And it's an exciting time for us as electrophysiologists and a great time for patients.
What an exciting time for our field. And so, I mean, thank you so much. This is so timely. We've been using the PFA quite a lot here, right? In thousands of patients, but some centers are starting to adopt it and patients are starting to learn about it. And so it's exciting and such a timely conversation. Thank you so much. In today's episode, we explore the rapid rise of pulse field ablation, PFA, and why it represents a major evolution in catheter-based rhythm management. Dr. DeSimone understands how this PFA differs from traditional and thermal radiofrequency, and he really taught us, what are the benefits of it? What are the safety distinctions that matter most from it, and how it's increased procedural efficiency, is reshaping our practice, but also still making sure that we're aware of those risks that go along with the procedure. Dr. DeSimone, thank you for sharing your expertise. We're so grateful for you. You've helped unpack this transformative technology we're now experiencing, our patients can benefit from. We look forward to seeing how this field evolves with some of those new catheters, as you mentioned, and really improving the patients we deliver care to.
Amazing. Thank you so much for having me. And thank you so much for doing this for our patients.
Thank you for joining us today. We invite you to share your thoughts and suggestions about the podcast at cveducation.mayo.edu. Be sure to subscribe to a Mayo Clinic Cardiovascular CME podcast on your favorite platform, and tune in every other week to explore today's most pressing electrocardiography topics with your colleagues at Mayo Clinic.
This has been a Mayo Clinic podcast.
At Mayo Clinic, relentless learning fuels world-class care. I'm Dr. Benjamin Hibbert, Chair of the Division of Critical Care Cardiology. If today's episode gave you a fresh insight, imagine what a full course can do for you and your patients. Head to cveducation.mayo.edu and explore our live and online programs, quick on-demand modules, and CME-accredited masterclasses created and taught by the very voices you trust here. Join thousands of clinicians who've already turned curiosity into expertise. Level up your practice now at cveducation.mayo.edu.